Welcome back for our next panel discussion on procurement in integrated care systems. I hope you've had a chance to make some new connections as well as using the platform to check in with delegates inside your network. Since 2013, clinical commissioning groups have been able to commission services from NHS recognised service providers for their local communities. As part of the NHS long-term plan, CCGs are to be incorporated into integrated care systems as they're seen as the future of health and care integration. Currently, 42 ICSs are operating across England in every area. Well, with me to discuss procurement in integrated care systems, I'm delighted to say we've got Pav Devsey, Director of Procurement and Contracts for the Barnet and Enfield and Haringey Mental Health NHS Foundation Trust, Edward Jones, Senior Policy Advisor, ICS Network, and we've got a last-minute step-in on this panel, Brian Mangan, Value-Based Procurement Project Lead, NHS Supply Chain. Now, don't forget to join in with our conversation by using our Q&A function, and please share your thoughts on Twitter using the hashtag NHE365. So good morning to all our panellists, and a big thank you to Brian, because we had a guest drop out and you're with us later, Brian, on a different panel, but you've saved the day and stepped in on this. So we're very grateful to have you with us. I'd like to start off by asking all of you to tell us a bit about what you do in this field. And Edward, perhaps we can start with you and your role at the ICS network and what you lead on.
Thank you, Helen. So the NHS Confederation's ICS network, we are the only membership body for integrated care systems, and we're delighted in this first year of statutory ICSs to have all 42 of the ICSs in our membership. So I suppose in that as a membership body, we have two functions really. One is kind of bringing together systems to share their experiences and learning to help them do the job that they've been tasked with doing, and the other is to lobby on their behalf on the areas we think that they need further support. My role within the team is leading on commissioning policy amongst other areas.
Fantastic. Pav, do you want to tell us a bit about what you're doing in your NHS trust?
Yeah, sure. So I actually provide a procurement shared service, which is for mental health and community trusts and sits across 3 organisations. So it's Barnet, and Haringey is listed here, Camden, Islington, and then also the North East London NHS Foundation Trust. And this came from us trying to collaborate on mental health and community spend, which is often not underlooked, isn't it? So so I think for me, it's been really interesting going on this journey for the past, ever since I think the inception of STPs, and how we straddle 2 ICSs now and have to work with our acute partners. So that's I think the key driver for me. How do we make sure that the mental health and community agenda from a procurement perspective is just really brought to the forefront?
And just quickly, Pav, how do you do that? And what aspect of that is keeping you awake at night? Because that sounds no mean feat to achieve.
So I think the most important thing is to make sure that our mental health and community priorities, that we keep raising the profile of them. And in procurement, I think it's often quite easy to think about the things that are tangible or the things that are really high profile. So we need to make sure in an acute setting, XYZ goods and services are there so that surgeries can get done, etc. And people tend to forget about some of the community things. So continence products, is it really that exciting? How tricky is it to buy? It is actually. So I think it's our job to just say, right, this stuff is exciting, and tell people how to do that.
Brian, a little introduction from you, if you would.
Yeah, good morning everyone. I'm Brian Mangan. I'm the Value-Based Procurement Project Lead. So I used to be a head of procurement back in the start in the NHS back in 2004. I've been working with NHS Supply Chain on this wonderful thing called value-based procurement. And really it's looking at, ways that it's not just about focusing on the price of the product, it's looking at pathways. And what I'm keen to explore, it'd be interesting to get some feedback today about how we can sort of, take the concept that I'm working on and how it can actually relate to integrated care systems as well. So I think what I've found when I used to be working in a hospital, what we very much focused on was very much about, what it meant to us as a hospital as opposed to what it means to the system. So yeah, I'm interested in exploring that today. So yeah, thanks very much.
That's going to be quite a big change, isn't it? I mean, all this, as Pav was saying before we came live, all this is very new, isn't it? But it also very exciting.
Yeah, it is. I mean, I think working together has been around. I used to work in an organisation called NHS Northwest Procurement Development, and I think I've mentioned before about STPs. So it has been a lot about trying how you get organisations or individual entities to collaborate. And again, that'll probably come out of the discussion we'll have this morning.
Yeah, collaboration is always key. And I must admit, it's a word that comes out very early on in all of these different virtual conferences and live events that we hold. Pav, let's turn to you then on that front. I mean, how can we work better across care settings with other procurement colleagues to get the best outcomes for service users, do you think?
I think the most important thing is to put the patient at the centre and think about what's the sort of type of product or service that could span the entire patient pathway, because I feel as if there's a vested interest in there for each of the organisations, and there's a way of working that could make things better for them, that helps us prioritise the right things. So yes, I think it's putting the patient at the centre.
Yeah, I'm sure that's something probably you'd agree with, Brian, patient at the centre. But what do you see to begin with as the practical challenges of ICSs collaborating?
I think that there are several. I mean, the first one probably is around culture. You know, again, what you're bringing is you're bringing sort of like very, very different organisations together. So you got the cultures both at a procurement level and a clinical level, because we're all trying to, if you like, looking at standardising. Because again, you take past points about putting the patients to the centre. It's very much about having that consistent level of care for the patients. So you got culture, you've got systems. How do we use the systems that we've got? Again, very, very different. Even in a very close geographical area, it can be one of us can be working totally differently to another. Then you've got again, it's about strategic objectives, making sure that they're aligned as well. So I think that those are probably some of the challenges that we've got. I think we all know we need to do it, but initially it's just making sure that everybody's sighted on the same thing, and we've got the governance structure that allows us to do that.
Before ask you another question, Edward, I just wondered if you wanted to add to any of that before we move on. Any thoughts crop up as Pav and Brian were talking there?
Yeah, I mean, I completely agree, understandably, with what Pav said about putting the patient at the centre. One of the things that's been really interesting talking to our ICS chairs and chief executives is how they envisage the kind of the NHS organogram. And you think about it, kind of traditionally in the old world, you've got NHS England at the top, and the money goes down to the regions, and then the CCGs, and then providers underneath that. Actually, when they've been envisaging the kind of governance and setup of the new systems, our members have been presenting us a kind of a series of circles. You've got the patient at the centre, and primary care, community care, building out to the system, the region, and the centre that way, and really hardwiring that fundamentally into the approach of what they're doing.
And Edward, why is the current structural reorganisation of the NHS so different from the ones that we've seen before?
So I think there's 2 points I'd make on this. One of this, I think that it's fairly uniquely when it comes to NHS reorganisations, if you'll permit me to use the dreaded R word, is that actually the degree of support there is amongst the sector saying this is the right approach. And I think that's very different from the landscape in 2012 and even reforms that have come before. And I think that buy-in's important. And actually, we've seen rather uniquely in public policy. Actually, as Brian touched on, a lot of the reforms have been coming in before an Act of Parliament was even produced, with STPs and ICSs operating in shadow form. So you've had legislation following delivery rather than vice versa. But also it's the point about collaboration that I think you just touched on as well, and that I think ICSs embody a fundamental shift in the organising principle of the NHS away from competition towards collaboration, and actually bringing all partners in the system together to say, how can we use the budget that we've got available to the best of our ability to keep people healthy, to improve health outcomes and tackle inequalities. Which means that the ICB is the commissioning bit of the system. It's actually more than just a commissioning body. It's a governance structure to facilitate bringing all partners to the table, which there's certainly a cultural change in how I think we're going to see the NHS behaving and across health and care as well.
And do you think, Edward, that it will make a lasting difference? Are you confident that this reorganisation is the right way to go now?
Well, I certainly hope so. And I think there's certainly a lot of optimism across the sector that this is the right approach. And we're already seeing actually a difference being made in terms of integrated working when it's coming to addressing the backlog and waiting times in many systems. But I think there are risks out there which are outside of the kind of the power of systems. And there's 4 things that we've been hearing from our members. One is their autonomy in order to be able to make decisions locally based on the particular needs of their population. 2, of course, as we know, the massive workforce challenges across the NHS, and actually having that capacity to transform the way we do things rather than just focusing on the job at hand, which can be really tough when we're working at 140% capacity and we know that many staff are burned out. 3 is capital investment to deliver the kind of state and the digital that our systems need. And 4 would be around the social care capacity that they've got in the system. This really is an ecosystem, and affect changes in one area or pressures in one area felt across the rest of the system. And that's an area that we're going to be working with our members on to see what we can do to address.
Before we move on, Brian, any additional thoughts? Pav, anything you want to add there?
Not really. I think, again, it kind of, reflecting on what you're saying there, I think from a value-based procurement perspective, what we're trying to do is engage with suppliers, if you like, and see them as part of the solution. I think there's a potential opportunity to work with industry in a slightly different way. You mentioned about the workforce challenges, about the challenge in delivering change. A lot of the things that we need to do, if you're up to your eyes in a hospital, you haven't necessarily got the headspace to say, okay, this is how we actually implement the change. And I think potentially work with industry in the right way that will help address potentially that particular issue. Yeah, so it's really interesting listening to you.
Pav?
Yeah, it is really interesting. And I think from a practitioner's point of view, so it's my 10-year anniversary in the NHS this year, and I've kind of seen different iterations of this. And going back to what you said, I think, Edward, we've had ways of working that we've tried to do with the STPs, etc., and we've tried to collaborate in the past, but it's never really got as far, I think, as it has done now. And I think there is probably something there around legislation coming first. So from a practitioner perspective, I think I see that. And I think the other thing that's also been really, really powerful with this is that there isn't a mandate to say you must do procurement in this way. We are allowed to shape it based on the maturity of our procurement teams and ICSs and ways of working. So so it does look and feel a bit different now, 10 years in.
I'm sorry, I'm looking slightly alarmed. I've done something crazy to my screen. It just put you all very large and taken away the audience questions. So actually, I might get my assistant, my husband, to try and fix my screen while we move on to the next question. So apologies for this, but it would be a shame not to get some audience. You seem to have sort of expanded on my screen. I can't work out how to go reduce you. Anyway, I'll carry on. Pav, how can we influence stakeholders across the ICS and further? Let's talk specifically about stakeholders, if we can.
Yeah, so I think there's probably lots of procurement people in the room today, and the basis of getting anything done and anything right is based on the people in the team. And I think we often find, we always find our teams are cross-functional. So we can't, I always use the term we have more influence than we have power. And I think it's really, really important for us to always remember that and keep that at the centre. And it's even more important with the development of ICSs, because now it's not even within our organisational boundaries that we can influence the nurse specialists or the IT directors, or whoever we're supposed to be working with to get the procurement over the line and get the goods and services we need for our stakeholders. So I think in terms of influencing stakeholders within the ICS and further, we really need to understand what drives them. We need to put patient at the centre again, and think about how it's going to impact them, because people come to their day jobs thinking about, I want to make sure I see this many patients, I want to make sure I deliver this type of IT service for my colleagues. So I think it's really about understanding what drives them, what's going to be important for them and feel valuable to them, so that when they come to those meetings or where they're putting specs together, we get the best out of it, and we can also feed that through into the rest of the project.
And more specifically, Pav, what's procurement's role in driving the value in the ICS alongside those stakeholders, both internal and external? I'm thinking what I might do while you answer that is I might just rejoin because my screen has gone very strange. So I'll rejoin and hop off. So if you can hold the fort, Pav, I'd be very grateful.
Yeah, sure, no problem. So I think in terms of procurement's role, our role is specifically to be able to align our stakeholders, because we know our stakeholders often have differing requirements, and just really to get them to see each other's perspective, and thinking about how we might do that across organisations who have different requirements at different points in time. I think that's probably where we really can add value. Brian, do you want to jump in there, being value-based procurement being your field?
Yeah, I think that, again, for us, it is about looking at doing things slightly differently. So we've looked. So there's two things about. One of the things I mentioned before was, I think the great thing about an ICS is it gives us the opportunity to look across the whole patient pathway and understand. So sometimes you'll make a decision in an acute. My background's working in an acute hospital. You make this decision in an acute hospital, not knowing the impact that it'll have out in the community. And obviously, from your perspective, probably vice versa, isn't it? There's certain things that you'll be doing, and I think what we've got now is we've got the opportunity to look across the pathway, to have solutions that deliver holistic benefits across a number of different ways. You know, for the obviously financial efficiency benefits, and for the patient as well. You mentioned that at the start, and it is about looking about how we can use procurement as a lever. Okay. It's not just a transactional. What I've been trying to do with procurement is really promote it, making a strategic contribution. You know, I don't know when you started in procurement. I know I did many years ago, and you know, it was I think my finance director introduced me as my new shopper. You know what I mean? So I think it's moved along a fair way, and that's what we're trying to do with value-based procurement. And I think the ICSs, ICBs are a real good opportunity for us to take it forward and lever the impact that we can have on it. So that was probably very long. That was probably a very long answer to a very short question.
Do you know, that was very good. Pav, Edward, and Brian, thanks for manning the fort there. I'm back with you now. Edward, what can ICSs learn from the clinical commissioning groups that came before?
So I think we did a piece of work with CCGs before the dissolution, asking exactly this question, and I think one of the things that really came up most strongly was the power of managers and clinicians working in partnership to drive change and improvement for patients. And I think that touched on the point that Brian was just making about that conception of value. And I think if you take that kind of collaborative approach and working together, and you put that into an ICS context, I think it's going to lead to systems looking at how they can, particularly in procurement of services, but also other functions, in terms of how they can look at the system return on investment. So it's not just about procuring a service in one area and what you get back for that, but actually how it has an impact right across the patient pathway, and how it reduces demand for other parts of the system, in order to make sure that actually resources are being used as effectively as possible, and taking all kind of staff who are involved in delivering that with kind of the system on that journey.
Fantastic. I think we're bringing our poll to an end at the minute. People on the platform today, what's currently the most challenging part of your role? And the answer with the biggest percentage is 40% is improving efficiency and reducing costs, followed by meeting social value and sustainability targets, which has got 30%. And then we've got 17% of people saying that their most challenging part of their role is supply chain resilience. and 13% say something else. That is actually something else as opposed to me saying something else. And it did make me laugh. Somebody, it's disappeared now from the live presenter chat, but somebody said that I looked like I was having my Prince Charles moment when my screen went crazy. So let's just hope that doesn't go viral. Thank you for that answer, Edward. And there was a question for you, but I think the question has also frozen. I think we've got a few gremlins in the system today. So if that comes back, I'll come back to you, Edward, with the question from the audience. Meanwhile, Pav, let's talk about wins that we can use to scale value. What do you think the key projects are that we can use there?
Yeah, so I think just to my earlier point, it's really important for us to find projects which sit across the entire patient pathway. And one of the ones that we're working on right now is for continence services and their products. So what usually would at an ICS level in the would be that there'd be high spend products, and those ones would be the ones that would be prioritised, and they generally tend to fit in the acute setting. But continence products and services was one for us where we actually have 300-400% more time to spend than the later acute. So we said we'd lead on this project. And it also has a service wraparound in terms of clinical support that's required, logistics for home delivery. So it really felt like one that would add value to the patients, and we can have a think about the different areas that we could look to introduce in that and review the specs. So yeah, I think trying to take a project like that from a mental health and community perspective, for me, that's valuable. And we have also used that to then further drive other clinical projects again, which might not have had the profile that they'd had in the past. So I think that's been really, really positive.
Brian, we always talk at all these events about skills and skills gaps. And what are the skills gaps, do you think, across current NHS procurement teams to meet the expectations of the government's CCIAF?
I think the main one, and I think people have recognised this, is around contract and supplier relationship management. I think they're kind of the two areas, because what you find is that I suppose in some ways, I don't want this to sound disingenuous, it can be everybody's job and nobody's job. I think it's sometimes quite difficult to understand, well, okay, whose job is it to manage the contract? And also what you find again is that when you're in a hospital environment, even though it's very much you see trying to go through your savings work plans being your priority, as opposed to actually ensure and working with the suppliers after the contract's been delivered to sort of ensure, first of all, that they're delivering what they say they're going to do, and the second one is working in this partnership way, working to continually drive the value and improvements through the life of the contract. And I think that the contract management will be accepted, I think, by most people, that it's an area that traditionally hasn't been given a great deal of focus. But as we move into the ICSs, you know, I think it's really critical that we get that upskill people and give them the time, and also promote the emphasis on it as well. To say, as part of your day job, managing the contracts is as critical as the other parts of your job as well. So that for me would be probably the main gap in the current skill set, if you like, for the procurement.
What do you see, Pav, as the main gap?
I think for me, there's something about capacity and capability. I think we often, Brian's first point, there's a gap between understanding is it everyone's job or is it anyone's job, and I think that summed it up beautifully. Some people might not have the time or the headspace to do it, and even if you do find the time and the headspace to do it, it's all on top of the day job, isn't it? I saw a visual recently, which and I think everyone here will probably would know this without this visual, but it said specifically that we've got 6 of managerial or whatever support in the NHS, which is quite a low benchmark compared to other industries which have 13 or 14%. And 2/3 of that, this is the bit that struck me, are clinical people. clinical managers, who have progressed up into other roles. So absolutely, and that's what we should be doing to support our staff. But we're asking people to do jobs which they're not trained in, and I think that's the biggest thing that across the NHS we need to recognise. So out of the goodness of our hearts and from a really passionate place, we try and negotiate contracts, or we try and look at doing procurement and understanding, Edward's job in terms of public sector policy. Like, that's all really difficult stuff. And kind of having the background, I know I understand it, but trying to explain that to other people can be really difficult sometimes. And then we're perceived as the blockers and all of that sort of stuff. So so I think capability and capacity for me.
Edward, capability and capacity, is that something that you see a problem with, where from your perspective?
Yeah, I think workforce and the skills are absolutely fundamental to what we do as an NHS. That our workforce really is the product, it's the offer, it's what we offer to patients. And just to reiterate what Paz said about managers, and I think sometimes there's this slightly lazy political attack on the NHS saying, we need to cut back on managers, and that's a particular bugbear for us in the conflict. The Paz says we are undermanaged compared to other sectors and actually other health systems across the country. And really, you don't want a system where, if you ask the clinicians and other staff who you want to be on the front line treating patients to be picking up other functions. Getting that skills mix is going to be really important. And one of the things that ICSs have been tasked to do is to produce system workforce plans working as well with partners in local government and other sectors. Which I think are going to be a really exciting opportunity to make sure that we actually have got that right mix of skills, evolve that mix of skills for the future, and look at how we can embed kind of approaches to joint working within the NHS and kind of with other partners into that skills mix.
Yeah, joint working is interesting. I was going to ask, actually, and perhaps kicking off with Brian, that will we ever see the trust procurement teams merging, do you think, to formulate true ICS procurement functions? I mean, is that an option? Would that work? Is that on the table?
This is a personal opinion. I think it's I think it's inevitable. I think it's an opportunity. When again, I've been around this for quite some time now in my previous roles. I think we have lots of. I used to work in NHS North West Procurement Development. We had 35 members. 35 things in 35 different ways. I think the ICS has given an opportunity to create structures that enrich procurement roles and create a career structure and all these other good things that are required. So that would, to me, I think is inevitable as we go forward, that they will evolve into ICS procurement, single procurement groups.
Do you both think that as well, Edward and Pav? Can you see that as going that way and being inevitable, and also, as Brian says, an opportunity?
So I currently sitting across two ICSs and working with a number of different colleagues. I see two very different ways of working. So I think it will be inevitable for some parts of some ICSs. But I also think that there will be different ways of working within other ICSs where, particularly in, I won't mention the ICS, but there's an ICS in up north, which when I was having a conversation with their directors, they were looking to bring it together, and they were on that journey, but the mass was just too big, and actually you had a couple of really good procurement leads there. So what they did was instead they carved it up so that there was collaboration, there was joint working, but I don't think we necessarily need to see every ICS with a single team, because why would you, if you've got maturity and if you've got some really good practice by going through, I think, processes of disrupting teams, etc. It's better to get the resources to focus on the right things and then perhaps work towards that in a future date or a version of that. So I don't think it's inevitable for all of them, but I do agree that there's a much better way of working closely together as a team. I don't think it necessarily needs to have a badge on it.
Let's take a final question. Oh, go on, carry on, Edward.
I was just going to say I completely agree with that, and I think one of our mantras in the ICS network is that once you've seen one ICS, you've only seen one ICS. We're talking about organisations that range from budgets of 0.9 billion to 6.9 billion pounds, cover vastly different sizes of population, and have different kind of within that different numbers of places with them and local communities, and starting from different levels of kind of how integrated they are. So I think it's going to depend on which system you are. I think sometimes if you're a supplier, you're going to find a higher level of complexity, which is engaging with the NHS, which is going to be a bit of a challenge. And it's also going to depend what you're procuring. I mean, I think there's a lot of a focus now on digital about how can we do things at a system level and share that collaboratively. But then again, there'll be other things that will be best done at a place level or a neighbourhood level, or by an individual provider, or by a provider collaborative. And it's going to be a lot more tailored to the situation, and we're going to see that variation. And it might be for emerging procurement teams, or you're going to have joint committees. It's going to be a much more varied landscape, which creates real opportunities to do things differently and more efficiently. But it does create that risk of complexity as well that we need to try and navigate our way around.
Absolutely. Just a final question for you, Edward. Jane says, as Edward said, it's about reducing health inequalities. So she's referring to things we were talking about earlier. She says, what plans are there to actually do this at community level? Because again, that kind of links with what you're saying about collaboration here. It's great collaborating, isn't it? But we've still not got to lose the individuality of the ICSs and putting patients at the heart and thinking about community level.
Yeah, I completely agree, and it's one of their statutory objectives of the ICBs as the commissioning bit of the system to address health inequalities. And I think particularly when addressing health inequalities, actually you need that local knowledge and able to work out the best approach, and often that's best done at a neighbourhood level. Not just GPs, but wider primary care colleagues have a huge amount of knowledge about the communities that they work with and the people that they see, and district nurses going into people's homes and understanding those areas and understanding the challenges, and that difference as well between demand for services and unaddressed need, and where we can refocus resources there. So that really does require, I guess, to some extent, a bottom-up approach in how we address this, taking that knowledge from a neighbourhood level up through a place and up through a system, and then having that reflected in the ICS's strategy and how they go about what they do. And that will shape the environment, I think, in which kind of procurement decisions are taken.
Sorry, I fibbed, Edward. One last question from Leslie, if that's okay. Where do you believe procurement ranks in the list of ICS priority that ICBs must tackle? Is it a true priority relative to everything else?
I think this is a really good question. I think that the number of times that I hear discussion about priorities in the NHS, actually we were looking at the NHS's operational planning guidance, which our colleagues at NHE helpfully published on Christmas Eve last year. And actually stopped counting the number of priorities. We reached 100. And this is a real issue, I think. We need to make sure that actually there's a smaller number of priorities set at the centre and greater freedoms for systems and then places within them to be able to set their local priorities and allocate their resources appropriately. I think specifically when it comes to procurement, this might be a little bit heretical, but I wouldn't probably view procurement as a kind of a single entity itself. Actually, it depends what you're procuring. Procurement of services, for instance, absolutely fundamental to what we do as an NHS, making sure that services reach patients. And procuring digital services is a really big challenge, and there's a lot of challenges around that in terms of availability of funding and funding flows and getting that to where we need it. But one thing I would say is I would expect an increased focus and attention on procurement over the next year or so, because we've got two big changes coming up on the horizon. One is that we're having the mandatory tendering rules and the current kind of procurement regulations for services abolished, and we've got a new provider selection regime coming in, which will give new freedoms and flexibilities to commissioners when they're procuring healthcare services and mixed services as well. And the second is there's a procurement bill currently going through Parliament, which will change the Cabinet Office procurement rules, under which all procurement of non-health services and goods sits. And that's something I think that in the Confed, at least, we're trying to get our heads around the implications of that and what that's going to mean. And so we're really keen to have a conversation with colleagues across the sector to understand. But I think when you've got both sides of that procurement puzzle being reformed, I think naturally that's going to draw a level of attention to how systems are doing to procurement that might not have been there before.
Brilliant. Thank you very much. Sorry to work you so hard at the end there, Edward, but suddenly I saw a few questions popping in on my screen for you. So another great conversation with a few gremlins in the system, but my thanks to Edward and to Brian and Pav. And thank you for providing some insightful questions and bearing with me when I had to rejoin the platform. I hope you got the answers you were looking for if you were somebody who put a question into the panel discussion. So let's take a 25-minute break to network with your fellow participants and take in all that we've learned so far today. Let's join back here at 11:35. See you then.
Bye, guys.
Oh, well done to the panel. I'm sorry it was an eventful panel.
No, it's good.
Thank you for keeping going.